Thank you very much for having me. So it's my pleasure to be here today to talk to you about these rapid access clinics. So what I'd like to cover is firstly a review of psoriasis as a complex multi-system disease, which I know you're already aware of, but also I'd like you to understand why the Psoriasis Rapid Access Clinic, or PRAC as I call it, came about, how it came about. We'll discuss some of the results and perhaps touch on future direction and potential of this type of clinic model. So why is psoriasis particularly suitable for this rapid access clinic approach? There's several reasons why. It's a common condition. With regards to the etiology, we know that about 30% of it is due to genetics. The other 70% is a little more uncertain, but it's probably a combination of environmental and other factors. 80% first develop psoriasis under the age of 40 years old, and that's significant because it's a particularly formative time. If you think about, where you're at then, it's a time where, you may be about to start university, start a career, relationships, and they can all be impacted by the development of psoriasis. It's a relapsing and remitting disease, and there's a high physical, psychological and social impact. So this graph here illustrates this cumulative life course impairment model associated with psoriasis. And what it shows is that psoriasis isn't just associated with the physical comorbidity, there's also psychological comorbidity and social stigma. And those can overwhelm an individual. And it's not surprising, even looking at the photographs here, you can see this hand where somebody has clearly got severe psoriasis, and I'd imagine it would be very difficult and painful to even use that hand. Plantar pustulosis can be difficult to walk. And here, scalp psoriasis, which is probably one of the more common phenotypes, or it certainly was in the rapid access clinic. And again, a high impact site and a significant amount of burden associated with it. It can be difficult to treat with topicals alone. So when planning the rapid access clinic, we started off looking at what the current patient pathway is like for psoriasis in the UK. And it's been shown that over 90% present to their GP for a diagnosis in the first instance. And within primary care, there's typically a stepwise approach, topical therapies being initiated in the first instance. And there is some research to show that patients may be up to 10 to 15 years sort of in this cycle. But we also know now, as I mentioned, that psoriasis is associated with comorbidities, so unhealthy lifestyle behaviours, comorbidities such as psoriatic arthritis and Crohn's disease, and also psychological comorbidity. And what happens is that these can build up over that period of time. And as an added layer of complexity, it's also been shown that some of these unhealthy lifestyle behaviours can actually worsen or flare psoriasis. Somebody mentioned in the audience earlier about stress flaring their psoriasis. And secondly, some of these lifestyle behaviours can also reduce the effectiveness of drugs and therapies for psoriasis. So there's a complex relationship that needs to be unpicked. So with regards to early intervention for psoriasis, this is a sort of a graph that I used in my thesis and sort of, I suppose, initially based the setup of the clinic on. So early disease is a key time to intervene. So if you look here, sort of where a person has developed or recently developed psoriasis, it is thought that a person is perhaps more likely to be receptive to management advice, that it's a teachable moment. Early disease is recognised as the key time for psychoeducational interventions and preventative strategies. Also, as a clinic, this would provide an opportunity to give real-world data, because early psoriasis is, I suppose, a subsection of patients that aren't very well studied at the moment. Also, by following up such patients, it would give an opportunity to perhaps apply a life course epidemiology approach to have a large cohort of patients and looking at their life outcome as the outcome of interest, and psoriasis and other things in their day-to-day life, be it lifestyle, stress, other medications, etc., as various other perhaps confounders. And also we touched on it there in the discussion, there is some evidence that early intervention with a personalised approach to care could modify the course of the disease. With psoriasis, the research is ongoing, but certainly with psoriatic arthritis and with all of the comorbidities associated with psoriasis, early intervention leads to better patient outcomes. So in setting up the clinic, I suppose there's quite a lot of work that went on in the background, kind of behind the scenes, and there were lots of stakeholders involved in setting up the clinic. The, I suppose, foundation was built upon by the IMPACT research group, which some of you might be familiar with, and that was an NIHR-funded research study that took place in Manchester, looking at comorbidities and psoriasis. And there was a strong focus on the patient interface with research user groups and focus groups, and that's really what I suppose sort of led to the foundation of what we did in the PRAC. So the aims in setting up the clinic primarily were to determine the feasibility of setting it up for patients who had recently been diagnosed with psoriasis. Would we be able to find this cohort and direct them into the clinic? But also wanted to describe the patients and their comorbidity level, provide a holistic service for recently diagnosed patients with psoriasis, and determine if the service led to an improvement in their outcomes. And also to determine whether attitudes towards understanding psoriasis improved following the PRAC intervention. So this is a sort of a flowchart representation of what went on. So patients could access the clinic via different routes. We accepted direct referrals from GPs primarily, but other healthcare practitioners. We also did some limited GP database searching as well at the start. Well, with regards to access, we had some brief sort of inclusion criteria. Ideally, developed psoriasis within the past 2 years, systemic treatment naive, and over the age of 16 for consent purposes. So within the clinic, patients saw myself, who sort of managed and assessed their psoriasis. We also had a nurse who collected data, but also had an educational role. And we also had a health psychologist who used so well material for motivation interview support for patients where indicated, and also ACT therapy, which we spoke about earlier with Catherine. A lot of data was collected, so demographic, phenotypic. There was also an option of patients donating blood for future genomic and proteomic research. I remember I mentioned this is quite a unique patient group. And then we screened patients, so for all of the comorbidities that we know are associated with psoriasis. And the idea being that, we were seeing these patients early and hopefully trying to pick up comorbidities, perhaps even before they were aware they had them themselves, acting on those, having good links with primary care and hospital services, and hopefully leading to better outcomes for them. So patients who had mild disease were referred back to primary care after the week 4 visit with a management plan and links to psoriasis management guidelines. There were also opportunities for further research if patients were interested, referral to the rheumatology clinic if psoriatic arthritis was suspected, and on to the systemic psoriasis service in Salford, where indicated as well for patients who needed tablet therapy. So the So Well patient material consisted of these leaflets. They've been digitalised since, and they're not just educational leaflets. They're sort of an interaction with the patient, and there's an opportunity for patients to, select what is important to them in terms of psoriasis and their comorbidities. They're encouraged to, I suppose, talk about very much so what mattered to them, what their goals were. And to make a plan, be that with a variety of things, perhaps maybe how to improve adherence to therapies, how to use their therapies better, and maybe how to make healthy lifestyle behaviour choices. During the course of the pilot, I became aware of this group in Salford called Health Improvement Services that acted as social prescribers. So I'm not sure if you've heard of social prescribing. I hadn't until I came across this group, but they're pretty much widespread throughout the NHS, but they're very much rooted in primary care and hadn't really much of a hospital interface, so they were particularly enthusiastic in getting involved in the project. And as the name suggests, they can prescribe social interventions, and I suppose I saw them as being a more maybe longer term and maybe tangible support for patients. So for example, if a patient identified that they wanted to give up smoking, then these social prescribers were able to prescribe nicotine replacement therapy. There was, opportunities for example, exercise classes, vouchers sometimes available for those. But also because it's a government body, they had links to the local council, so we're also able to advise on things like debt and stress and so on. So I did mention earlier that we did collect some samples, some blood samples, and it is envisioned that, I suppose going forward, looking at psoriasis, trying to understand the natural history of psoriasis and why the disease evolves as it does in certain patients, will probably come back to relying on what we call big data. And what that means is combining details about a person's sort of genome and proteomic research, or data rather, with their other data, be it phenotypic data or how their psoriasis works physically, in combination with other demographic factors for the patients. So large numbers of patients will be needed really to inform this model. But going forward, in terms of how we study chronic immune-mediated inflammatory diseases, it probably will be through using a model such as this, where sort of various patient data are combined. And that's something we would look to in the future, perhaps. I've just included here the top 10 psoriasis research priorities, which were published in recent years. I know the Psoriasis Association were involved in this, and a lot of you will be familiar with these. And I think just reading through these, I think you can see that the model of the PRAC could potentially align with these, or at least sort of be a platform for looking into these research questions further. So number one there, do lifestyle factors such as diet, etc., play a part in treating psoriasis? So, that is something that we were sort of actively looking into. Does treating psoriasis early reduce the severity of the disease, make it more likely to go into remission? So that, of course, was what the Rapid Access Clinic was all about. Now, we were, I suppose, tied by, of course, by guidelines, and followed those in terms of the treatments that were available to us, following NICE guidelines and so on. Because what we do know is that there's a lot of under-treatment out there in terms of how psoriasis is being managed at the moment. And we sort of saw the Rapid Access Clinic as a way of kind of identifying patients who are most at need, and perhaps pulling them through the system a bit more quickly. Factors predicting how well psoriasis will respond, would be, I suppose, through the biological collection specimen of PRAC. We did ask specific questions there for number 4 about, itching and burning, etc., which could be mapped to the treatments we're prescribing. And how well do educational interventions work? So I'll touch on that a little bit in the results section. And does treating psoriasis help improve other health conditions such as cardiovascular disease, psoriatic arthritis, and so on? So as part of the consent process in the clinic, we did ask patients if we could sort of prospectively access their medical records through their GP, just to see if, for example, we picked up through screening things like high blood pressure or high cholesterol. Could we then see if that had been acted upon and if it had made a difference to them down the line? And we do have fantastic electronic patient records in the NHS, and possibly as a resource, it's often underutilised. So just moving on to some results. So with regards to the pilot research component of the clinic, baseline participants, we had 39. We had week 4 follow-up data for 35 of those, sort of largely due to sort of COVID hitting just around about then. This slide is a busy slide, so I'm just going to draw attention to the important bits. It's basically describing the patients who attended the Rapid Access Clinic. And I suppose an important thing to say from the outset that was promising was that the median disease duration was less than 2 years for patients attending, and the median age was 33 years old. So we were quite happy that we had, sort of broadly speaking, found the correct patient group. We asked patients the site of their psoriasis, and I suppose thinking about psoriasis assessment, we've talked about PASI and DLQI, and we touched on the fact that often it's not the best measure for high-impact site involvement. And we did ask about high-impact site involvement in the clinic, and it was just quite striking that 90% of patients had at least one high-impact site, and 46% had 2 or more. And then, interestingly, looking at, I suppose, how much psoriasis affects their work and productivity, bearing in mind that this was sort of a younger adult cohort, it was quite striking that almost half, so 48%, felt that treating their psoriasis had impaired their productivity while working over the preceding 7 days. Looking at lifestyle behaviours, there were quite high levels of unhealthy lifestyle behaviours, be it smoking, alcohol, or reduced exercise, sort of higher than we would have expected to find in a normal population, and BMI as well. already high, with most patients being either overweight or obese. When we screened for comorbidities, we found hypertension. Well, we found new cases of hypertension in 13 cases, so 33%, and one additional case where it was sort of inadequately controlled pre-existing hypertension. And also when screening for cholesterol, we found quite a lot of new diagnoses there, as you can see, so 14 out of 34. And I know these numbers are small, but I just think it tells an interesting story, really. And then moving on to kind of psychological comorbidity, what we found were high numbers of patients at risk of clinical anxiety and depression. As you can see there, when we used the HADS questionnaire to screen for a possible mental health impairment, we found that almost 36% were reaching caseness for possible anxiety and 23% for depression. We followed these patients up at week 4, and what we found was that there was a significant improvement in terms of the extent of their psoriasis, various quality of life measures such as the DLQI and physical symptoms. We used this tool called the Brief Illness Perception Questionnaire and saw that there was a significant change in terms of patients' perception of control over their psoriasis, their understanding of psoriasis and the treatment plan, and their belief that their treatment could help their psoriasis. We also asked patients sort of more specifically about the incorporation of the So Well intervention into the clinic, and the shaded areas here correspond to positive motivation and intentions, whereby sort of the vast majority of patients reported positive motivations and intentions to find out more about psoriasis and treatment and to make healthy lifestyle changes. We did ask if there was a change in anxiety, because one concern we had was that because these patients had just been recently diagnosed with psoriasis, that it might actually be a bit overwhelming to give them all of this information about comorbidities and future risks and so on. But there wasn't an increase in anxiety, and I think that there was a big focus in the clinic on not just education but on empowering patients as well, and really just trying to make everything very positive, and I think that kind of filtered through. So these were the therapies that people received in the clinic. So 38% just had only topical monotherapy, 44% were referred for phototherapy, and then smaller numbers, so 13% referred on for systemic therapy, and some being referred on to rheumatology for assessment and on to the social prescribing services. So I've just included this graph because it was sort of a discussion point in my thesis. I had shown you earlier this graph depicting time as a factor for cumulative life course impairment building up in patients with psoriasis. And if left unchecked, a person can sort of cross this threshold, this dotted line here, which almost looks like a point of no return. But I feel that certainly when psoriasis is diagnosed, which you can see here in the graph on your right-hand side, I think that there is certainly quite a significant spike in terms of stress levels, in terms of comorbidities, certainly is evidenced by the research that we've done in Manchester, and unhealthy lifestyle behaviours, albeit as perhaps coping mechanisms or otherwise. So again, it just adds, I suppose, further strength to this early disease stage being a key time to intervene, being the most appropriate time to educate patients about their psoriasis, to screen for comorbidity, and ideally by acting at this early stage and intervening appropriately. Hopefully you could, the dotted red line there is where the curve has been flattened and a person doesn't sort of reach this threshold up here. But also, I suppose nothing in life is a straight line really, and I think it's important, for patients to know that there isn't, a point of no return as such, and that it's important to be optimistic and very hopeful about psoriasis because, even though there isn't a cure, we've got some fantastic treatments available, and fantastic services in the NHS. Perhaps we're not always very good at integrating them and linking them up together. So in terms of future direction or what's going to happen with PRAC, so health economic modelling is going to be very important. The question is PRAC value for money? So our hypothesis is that if you invest and you spend money basically on patients early in their disease through this sort of a model, well then down the line you will save in terms of health and social care costs because these patients will have been better managed. And this sort of model of care could therefore be a blueprint for other chronic disease management. And there's a lot of interest around this at the moment because chronic disease management is the main thing that the NHS is spending money on, NHS and social care. It's overtaken acute and other cancer services and so on, and it can't kind of keep going on like this. And one thing that a lot of these chronic diseases have in common is this sort of comorbidity, burden and clustering. So there is a separate body of work that's ongoing that is in conjunction with the Department of Health Economics at the university, with Catherine Payne and also with Darren Ashcroft, who spoke earlier today. And we're just looking at whether or not patients with psoriasis have greater health service use costs associated with them due to increased levels of comorbidity. And from the preliminary data, it's suggesting that could potentially be the case, but we haven't finished that. And it is envisioned that perhaps results from that study could serve to create sort of a health economic modelling tool for PRAC to kind of try and have better information as to whether it will be cost effective. The Rapid Access Clinic was included in the Dermatology Getting It Right First Time report, which is good to see, and I suppose getting it right first time is all about improving early access to services for patients. I do think that some of the strengths of the model is that it's flexible and it's adaptable, depending on, I suppose, what resources are available and what service needs are in an area. So in conclusion, the PRAC is an innovative clinic which combines service development with research opportunities. It aligns with a lot of research and policy agendas for psoriasis. There are some positive results from the pilot, and it could potentially be a blueprint for managing chronic diseases going forward. I'm happy to answer any questions. Thanks.
Okay, thank you very much for your talk, Julian Nash, Bristol Myers Squibb. Before I joined Pharma a couple of months ago, I was a consultant rheumatologist for over 20 years. So we're very familiar with the concept of an early clinic. But we had the advantage that we were mandated to do it, and we were audited on it, and it was a national guideline. One of the things we had to do was educate our colleagues in primary care as to the type of patient we wanted in that clinic. Ideally, somebody with likely rheumatoid, so we could get them on systemic treatment, review them at 3 months, and if needs be, put them on to advanced therapy. Because data suggests that if you do that, you can sometimes take patients off advanced therapy, and they retain remission on systemic treatment such as methotrexate. So I have 2 questions. My first question is, what have you done to interact with your colleagues in primary care to get the patients into your clinic as early as possible? And secondly, you're not mandated to see what is viewed as a chronic inflammatory condition, whereas we would deal with an early inflammatory condition with possible long-term joint damage. So will you be able to take this forward with the current pressures on seeing cancer patients and a 2-week target in dermatology?
I guess answering your second question first, you're right, because it's not included on the quality outcomes framework. GPs basically won't get paid or reimbursed for sending patients on. So that's why I think, well, that's why we have to sort of at least prove it as a concept in a pilot capacity like this first, and have those results to roll out, I think, to take it further. Now, with regards to interacting with GPs, I did, I suppose, quite a lot of groundwork interacting with GPs locally in Salford, where the pilot was, sort of attending their meetings, teaching them, etc., sort of turning up at any event, really. And I think that really worked, and I got a lot of positive feedback from them. What was also very helpful was the Clinical Research Network group. So we got on the CRN portfolio after our ethics approval, and they were sort of like a link person between us and GPs, and I suppose gave a bit of credibility, as it were. But also they offered sort of it was a small financial incentive, but it certainly helped in terms of the time we're asking from GPs. So that was helpful in just getting the pilot off the ground. So, yeah, I think, you know, rheumatology or psoriatic arthritis has that advantage, really, that's how the system is. So the onus is on us to prove that this is not just a good idea, but is cost effective, which is what we're sort of working on. The unfortunate thing is that the actual tools to show that it's cost effective are still almost sort of in development, because there's so much talk about preventative healthcare. But you know, governments still often just think in shorter kind of 5-year sort of cycles, really. So there's so much talk and so many inches of policy papers about it. Yeah, you're right. We're dealing with the here and now, and lesions we've been inundated by them. But I feel we have to sort of make a stand as dermatologists, and obviously everyone in this audience is such an advocate for psoriasis that, you know, there's so much potential, I think, for a service like this doing so much good that it's sort of worth persevering with.
Well, I have to say that there's a very selfish motive in asking Claire to speak today, because I, as clinical lead for NHS England dermatology, I think this model is a no-brainer, absolute no-brainer. And I wanted to present it to members of the association, and it's great that Chris is here, he's a great advocate of it. I think it's an incredibly flexible model. I think there's huge potential that this could be done on a wing and a prayer to a large degree. I think, you know, if you've got a good specialist nurse in Lincolnshire, they could go to Skegness, which is 40 miles away, and they could see everybody that you want to send with psoriasis as a GP. I think it could be done quite quickly and quite easily, and we've got overwhelming data that it would be good. So I think it's great to hear positive feedback, and if anybody wants to contact the association that has listened to this today with positive thoughts on it, then that is incredibly powerful for us, because the patient voice is what counts if we want to take forward these sorts of models. But the work that I've been doing with the Outpatient Recovery and Transformation team is all around new ways of working, different ways of delivering services, and this ticks all of the boxes. I think I've got 2 hats on here, and the other hat is as chair of this association now. And I think one of the conversations we need to be having is that the single most problematical reason that people ring the helpline with is that they cannot access services. So if we could get these clinics running, a lot of my people that I talk to with psoriasis would just like to go somewhere, chat to a nurse, learn how to use their creams, understand about how much quantities they should use, and know what's available. And so I think this is a no-brainer, and we've got to try and work out how we can get it funded. Thank you. Thank you very much.
Thank you, Claire, for a great presentation. I think from my side, with my GP background, it's not more of a question, but just a comment, really, because I find the more conversations I have about the setup of general practice within the UK, the more I find the audience who are listening quite surprised about how things will work. So I think it's just important to recognise that when we're talking about GPs asking for funding or GPs asking for money or not having the money to do something like this or support this, it's important to recognise that actually each individual GP practice is run by the partners. It's an independent business that is contracted by the NHS, and it's the partners that are responsible for the financial viability of that practice. So if there's no financial viability, that practice closes down and those patients will have to be moved to other practices. So the idea for asking for financial payment for services is in order to get the right resource into the practice and then deliver the service that's required. So as a GP, I think this is incredible, and I think it's got legs. As you say, Julia, it's a no-brainer. But I just wanted to make that point, really, just to make it clear that it's not GPs asking for more money in their pocket to do it. It's actually to be able to provide the service for patients.
I think we need to move on now.
Okay,
Claire, thank you
great,
so
thank
much
you.
for that.